I really like to cine where the transition point is between my extra plaque and my true lumen. One, it lets me know that my ADR was successful, right?
Hey everybody, Chris Brown here with another video for Murmur. I am fortunate enough to be joined by Robert Riley, Director of the Interventional Cardiology Program at Cath Lab, Complex Coronary Therapeutics at Overlake Medical Center in Bellevue, Washington. Also, close personal friend of mine, really just fantastic operator extraordinaire here. And we are going to have him walk us through IVUS-Sighted ADR for CTOs. And this is really a treat and very fortunate to have this. So, Robert, thank you for doing this with us.
Absolutely. Thanks a ton, Chris, for being on, and thank everybody out there for tuning in. ADR, or Antegrade Dissection and Re-Entry, I think gets a bad rap sometimes because it does take some repetition to learn the skill to do it well. But I will tell you, initially, those first 10, 15 cases are definitely a lot to go through. There's a lot of steps, but honestly, now that I'm comfortable with ADR, I love ADR because it's safe, it's relatively reproducible, and it's a great option for patients where wire escalation isn't an option, particularly in those patients that you may not be able to or have the desire to go retrograde in. So I think the first thing is, when to utilize ADR before we get to the case presentation. If you look at, we could go through this big algorithm, go through the steps, but really what it boils down to is long CTOs. A long time ago, there was a analysis done that anything over 20 millimeters, the likelihood of you wiring true to true wire escalation dramatically dropped. That was sort of the inflection point. So longer CTOs, it's just sticking stiff wires um, through long segments through arteries. Just it doesn't make sense, right? Because it goes lots of different ways, and it's
Yep.
particularly when we're talking about non-jacketed sharp wires that they go where you push them. So long CTOs, and then you've got to have an area where you can do reentry. The common example that we'll see in this is an RCA. So when we look at an angiogram, we see, oh, it's a long CTO, but proximal to the bifurcation, there's actually this area of somewhat normal looking tissue, meaning not heavily calcified, not severely diseased or stenosed. That's an area where we can do dissection reentry. We need a reasonably healthy lumen because what we're going to do is get into the extra plaque or subintimal space, depending on what term you want to use. We're going to put a device into that space and then use wires to puncture into the true lumen. So if you've got a really heavily calcified area you're trying to do this in, you can do it. It's just a little more challenging, right? Because you still get calcium both in the intimal and extra plaque or subintimal space in a lot of these cases. So having to traverse that with wires can be difficult. Um, and so this is a really good therapy for patients who have what we call a landing zone in that area. And we'll show an example. This is not for cases where the distal cap of your CTO is at a bifurcation, because you're still going to re-enter and you're still going to potentially cut off one of those branches. And we know with CTO PCI, any branch greater than 2 millimeters does have prognostic value. So we'll kind of illustrate this a bit more. But clinical presentation here, so this is an older female with lifestyle limiting angina despite multiple meds, low EF, as you can see, prior cabbage with limited LAD and SVG to RCA. Was having a lot of symptoms, and they knew that there was a potential problem with the SVG to RCA, so was sent for a CMR. Showed viability everywhere, right? And that makes sense, right? Because they're having angina. So they were sent for right heart cath and coronary angiography, not volume expanded, right? So not heart failure causing these symptoms. Cardiac index is on the lower end of normal, but okay. And angiography showed a patent lima, failed SVG to RCA, no big disease in the left main or cert. So we know it's the RCA, right? We know it's viable on CMR and because she's having angina. And we know that it's a potential target because there's a failed graft there and it's the dominant vessel. So these are some of the angiograms. You can see a patent lima. You can see a big septal cascade with left to right collaterals. You can see the left main of the circ is okay. You can see a big epicardial as you come here over to the RPLV branch. And you can see here's the dominant RCA, big CTO there. So we don't know much from this. We know that RCA is a CTO. We know the proximal caps here proximally. And we know, as you can see here, that it's a relatively long CTO. What I always tell people when you're doing diagnostic angiography and you have a CTO is that you want to match your angles. So this is a traditional LAO view. what you want to do with your LCA system that make for high collaterals is do the same view. Because if you do the same view with both your retrograde collaterals and your antegrade, you can actually match up how long is it, where's my landing zone, and all this. So now, if you look at this angiogram, I wanted to talk to you a little bit what I mean about a distal landing zone. We have a relatively unambiguous proximal cap we saw here. The retrograde collaterals show us that the distal cap is proximal to the bifurcation, and there's a relatively healthy, area for reentry right here, right? CTO is nothing is healthy, but there's a good lumen here. It's not heavily calcified. This is what we consider to be a good lumen. So again, longer CTO, because we did it in the same exact views. We know it's longer. We know that there's a good distal landing zone. If we can't do ADR, we do know that there's retrograde collaterals. What we don't want to do is spend a bunch of time with wire escalation here, because again, it's a long CTO, the likelihood of wiring true to true is low, and we can be much safer by utilizing knuckles to traverse the subintimal or extra plaque space and set up for ADR. So
And
here's our
just so
dual angiography.
we can be
Oh
clear
yeah,
to everybody, Robert, describe your wire choice for the knuckle,
oh
features
yeah.
of the
We're going to
wire
go
that
through
make it
all of it
good.
right here.
Okay, good. Just making sure.
Absolutely. So this is a post-cabbage case in a previously failed attempt by somebody else. So when another operator who does CTOs fails a case and gets sent to me, particularly in their post-cabbage, I will still go bifemoral. Maybe that's a little old school with me, but this is, as again, illustrating what we saw with diagnostic angiography. You can see you've got a proximal cap. There's a relatively good taper zone here, so it's relatively unambiguous, although there are a few branches. So it's not completely unambiguous, but it's reasonable enough for me. You can see there's a relatively long, over 20 millimeter landing zone. And you can see down here, again, a good reentry area. So for me, if I go through the hybrid algorithm, this is an ADR case with a retrograde bailout. And the retrograde bailout would be RDR because we'll already have some gear here, and we'll do retrograde dissection as a bailout here. So with that in mind, and again, this is a bifemoral system, both 8 French guides. You can see an AR here, EBU-35 here. I get myself here with a 135 Corsair Pro microcatheter and 8 French trap liner. We always bring in guide extensions Antegrade with CTO PCI because, again, it's a CTO. We need this extra backup support, as you can see here. My microcatheter is here. I actually take a Pilot 200, as you can see here. What I do is I drill it into the proximal cap. I make sure I'm dancing in multiple views, and I quickly fold it over into a knuckle. The reason for that is, again, I don't want to transverse long spaces with sharp wires, even jacketed wires. So I quickly turn it over into a knuckle here. Now you have to remember with Pilot 200, they fold over much further back than like a Mongo or a Fielder XT. So you're going to make a much bigger knuckle. And in fact, they fold over right at the transition of the radio opaque and radio lucent area here. So the knuckle can be hard to see. You actually have to cine in order to see the knuckle. You also got to remember that because it folds further back, it makes a much bigger knuckle than, again, those XTs or those Mongos, which are meant to fold over right at the tip. So they make smaller knuckles, which have different purposes than these bigger knuckles. This bigger knuckle on the Pilot 200 is nice here because it's stiffer than a small knuckle, and so it will traverse down calcified vessels like this much easier than a small knuckle, and it'll stay out of some of these smaller branches that we saw here, whereas a Mongo or Fielder XT with those smaller knuckles will often pop into and mini star into. That doesn't actually help us, right? Because it just gets us into
No.
a branch. We need a bigger knuckle to traverse longer spaces. So then we have two options. So we have, these are two RCA CTOs, literally almost the same case. And it sort of depends on your lab. Older, sort of old school technique would have been to switch out for the knuckle for a crossboss. And a crossboss is a blunt dissection tool that once you get in the extra plaque space, you actually spin and it takes you all the way down, will keep you in the extra plaque space down to the area where you want to do your ADR, which again we talked about is distal to the distal cap of the CTO. And in that area of the vessel that we think is healthy, that we can do dissection re-entry, that landing zone. Honestly, I haven't used a crossboss in, I don't know, 2 years. It's been a long
Look,
time
my crossboss
because,
expired, so I was going to ask you if I should buy
yeah,
one, but it sounds like I'm
yeah,
okay.
yeah, all of my cross bosses are expired, but I did want to show this because I know there are still some labs with cross bosses on the shelf, and it is an option. Um, Really, the last couple of years since the diffuse uptake of the Mongo wire is we really switched to doing ADR with the Mongo wire. It's a jacketed wire. 4 and some change gram tip that is designed to purposefully fold over right here at the tip and make a knuckle. What we do is we take the big Pilot 200 knuckle down here to, again, traverse those small branches. Then we knuckle de-escalate, just like we talk about wire de-escalation. We don't want to take the big Pilot 200 knuckle all the way down here because that's a lot of space with that big knuckle that we're dissecting. A lot of space means a lot of potential for hematoma, even when we put our guide extension down like this. One important piece of reducing hematoma formation as we dissect down is getting that guide extension in. That's a key piece of ADR that's important. Hematoma is bad, right? Because as that hematoma fills, it'll pinch down this true lumen, making our ability to enter the true lumen much reduced compared to if we don't have hematoma. We'll talk about some other strategies to reduce that here in a minute as well. That's why we
I think that's a
de-escalate.
really important point, though. I want you to maybe
Yeah,
say it one more time for everybody, because you're managing the blood flow from the aorta into the extra plaque space that you have
all the way
created with
down.
your knuckle. And you don't
Yep,
want to fill that up, of course. And so
yep.
Robert has moved that guide extension as far in as possible to essentially make the pressure on his hemodynamic system look like it's
Yep.
flat.
And sometimes it's not just pushing. Sometimes it's using
Yeah.
balloons to get it in. Sometimes you have to pause knuckling down to do that. But it's really key to get this down there to block the inflow from the aorta down here, because you see the true lumen here. That will compress further the more hematoma. That's why we use the crossboss or these small knuckles, because look at the profile of this compared to this. See how
Yeah.
big this
Much
knuckle is?
smaller. Yeah.
Much bigger. We really want to minimize that by using either the low profile crossboss or, again, traditionally the Mongo. These days, we used to switch out for this for a stiff wire Miracle 12 in order to then deliver the Stingray. These days, actually, ADR is much simpler. We actually knuckle de-escalate to a Mongo, take the knuckle down to right here, and we can actually deliver the Stingray right over the knuckle. So the Mongo really serves to traverse the subintimal space or extra plaque space all the way to the landing zone. And then we can actually take the microcatheter out and switch out for the Stingray device. So things are much simpler today than back when we started ADR over 10 years ago. So as you can see here, the guide extension is still in. My Mongo was down. I've delivered what this is called a Stingray device. The reason it's called a Stingray is because it's got these fins, right? And if you can imagine, looks like a Stingray to some extent. So what we've done is we've taken the Stingray all the way down to our distal reentry zone. It's in the extra plaque space, right? And what we want to do is utilize this to get into the true lumen or intraplaque space here, okay? The Stingray has two little radio opaque markers on it that we'll see here in a minute. It also has two exit ports that are diametrically opposed, 180 degrees to one another. One is more proximal and one is more distal. What you do is you want to exit one of these ports and go into the intravascular space. Now, you don't know which one is pointed which way, because if you imagine the Stingray rotates as you advance it down, so you don't know which one is up and which one is down. But what you do is you selectively probe them to see. Now, one of the very important pieces of doing ADR is that once my Stingray is in place, I always want to do retrograde angiography, because I want to see, is my Stingray below or above the actual true lumen? Because if you think about it, the extra plaque space is all around the true lumen, right? If you think about how your
Mm-hmm.
artery is set up, there's extra plaque space all around the true lumen. Your Stingray, your knuckles, and subsequently your Stingray can barber pole all around. So it can
Mm-hmm.
be above the true lumen, below the true lumen. But doing retrograde angiography before you start trying to stick things through this will let you know, do I want to find the port that goes up or down? Because I want to find the one that goes towards the true lumen. And again, through one of these two ports. So the other piece that's really important is that finding the true orientation or the correct orientation of the Stingray. The Stingray has these two little radio opaque portions you can see here. The thing is, when it's focused this way, it's flat and you're looking at it like this. That means the wires would stick directly at me or the other way. I can't orient that in space. What I want to do is turn it to where it's flat, where I'm looking at it flat, like this. This is what you're looking for. So you honestly have to almost always move to a different view. So this is an LAO, and I got lucky in this view because look, this is exactly what I want to see, because when it's flat like that, I know I'm going to go above or below and I can see my wires. If it's like this, it's going to be coming out or in and I can't see it. So I often will have to move my eye around to find that spot. I also like to mag up for this as well, because again, this is really small stuff that we're looking for. magging up can be helpful in that situation too. So I usually mag up from a 22 to something more magged up from there. But again, this is what we're looking for, is to see it turned like this so that we know we can see the wire going up or down. Oh, the next thing we do is now what do we have? We have our Stingray down in the extra plaque space. We've oriented it, right? We've moved our eye around to where it's flat, where I can see my wires going up or down. The next thing we want to do is withdraw any hematoma from the dissection that we've created coming down. This is called straw, or subintimal transcatheter withdrawal of fluid. And this is a video I made to kind of show what it looks like.
I think only you can hear the commentary for this, Rob, so you're going to have to talk
Oh,
over the
no.
video here. It's
Oh, okay.
okay, though?
I didn't realize that. So what we've done is we've hooked up a large syringe to the back of the Stingray. So there's the over the wire port at the back that we put a big syringe on. We then keep it negatively held and put a, yeah, you can't hear any of that. And what we do is we put some forceps right on that to keep the negative pressure so that creates a vacuum. It's sucking hematoma from the extra plaque or subintimal space in order to evacuate that. What that does is decompress the true lumen from that hematoma to make the likelihood of us being able to switch to stick in and out of that much higher.
Yeah.
So we really
And
do that every time that we do ADR.
And I think when you do a good job with this, at least in my experience, you actually do get to see that lumen get a little bit bigger on the retrograde angiography, and it does make you
Mm-hmm.
feel a little extra confident about what you're doing,
Absolutely.
and
People
about
often
where you
ask,
get to land.
yeah, absolutely. And people often ask, how long do you do it? Depends. If you start seeing a decent bit of blood come back, which does happen from time to time, that's okay. Then just wait longer. If you're not seeing much, well, that's great, actually, because that means you don't have a lot of hematoma and you can kind of move on with your day. But I usually, once the Stingray is in place, I just start this right away so that then what I'm doing is I'm hooking up the other aspect to the insufflator to put the dye into the Stingray device so that we can visualizing it, moving my C-arm around so that we can see our proper angle. By the time I've done all that, usually I can take a look at the syringe and be like, oh, either there's a lot of blood coming, I'm going to wait for another minute or two, or, oh, looks like we've kind of stopped, so now we're going to take that off. So now we've evacuated our hematoma. We've found the right projection for our Stingray device. Now it's time to actually try to use the device in order to get into the true lumen. What you can see here in retrograde angiography is that my true lumen is above the Stingray device. So I know I want to find the lumen that's above it. And there's two different ways of doing the reentry aspect. You always start with a stiff wire. And back in the day, we used to use things like Hornet 14s, Miracle 12s, just some stiff wire that would essentially fenestrate the subintimal or extraplaque space into the true lumen. These days, actually, I've started taking to a Gaia 3 Next because it's a stiff wire that's highly torqueable that actually already has a CTO bend put on it and comes out of the Stingray pretty perfectly. But what we need is some sort of stiff wire that'll go in. And what we're doing is we're drilling and we feel a pop and release in it going forward. That's the pop and release through the extra plaque or subintimal space into the true lumen. You don't always feel it, but that's kind of the idea of what you're going for. If it looks like it's following a reasonable path, you can do what's called a stick and go or stick and drive. And that's where you do retrograde angiography to see if your stiff wire is in the true lumen. If so, you're good. You deflate the device, it comes out, microcatheter comes in, switch out for a workhorse wire as one does, and then proceed with PCI. If there's anatomic ambiguity or you're just not feeling comfortable, then typically what we do is we do a few passes of that wire into what we think is the true lumen, spinning the stiff wire as it comes back into the Stingray device, then go back out, puncture again, spin it as it comes in. The reason we spin it right before it comes into the Stingray device is to, again, create a larger lumen connection between that Stingray and the true lumen. After we've done that, we then take a jacketed wire in. Again, and that's called a stick and swap. So that means I've stuck with a stiff wire and I've swapped out for a jacketed. That can be a Mongo, Pilot 200, Glide. It's just some sort of 4 to 5 gram tip jacketed wire. In this case, you can see I've stuck with a stiff wire and I've actually swapped for a jacketed wire, as you can tell here. And you can see I'm in the true lumen of the PL. So then what we want to do is switch out for the workhorse as we talked about. And the next piece is crucial. I'm actually going to pause this. as the it's really important as you take the Stingray device out to really watch your wire. I've seen a lot of successful ADRs when proctoring where people get excited. They're like, yay, my wire's in the true lumen distal. I'm going to take the Stingray out, and they lose wire position and actually come back proximal to where they stuck to begin with and have to start all over because the Stingray device is flat. And remember, it's having to twist through the subintimal space. It can be pretty tough to actually get it out. So you really want to watch that wire position. The next thing that's really important is as you take the microcatheter in to switch out for whatever wires in your true lumen for your workhorse wire, you have to spin your microcatheter through the transition point from the extra plaque or subintimal space into the true lumen. Remember, you're going through tissue. I've also seen a lot of successful ADRs. We get the wire in, we're excited, Stingray comes out, great, let's move on to PCI. Microcatheter goes in. You don't spin between the transition between the extra plaque and the true lumen, and it bucks, right? And anytime a microcatheter bucks, you create tension and torsion. Taking the wire back, you lose wire position and you have to start all over. So it's imperative that you always spin the microcatheter between that transition because you're going through a tissue plane, right? All right, so now my workhorse is in. I've taken my microcatheter out. It's time to IVUS. And what I really like to do, let me just bring this back. I really like to cine where the transition point is between my extra plaque and my true lumen. One, it lets me know that my ADR was successful, right? I feel pretty good at this point because I've confirmed with angiography and my workhorse wire feels free in the distal vessel, but IVUS is always the last check. It's important to know where that is, not just to confirm that you did successful ADR, but also where you're going to have to stent. You got to stent distal to where you did your transition, right? Or else you're not going to connect the spaces appropriately between the true lumen proximally, where you went subintimal, and the true lumen distally. And you got to connect true to true, or else you're going to miss a lot of your distal branches. So this IVUS is really key. And what you're looking for is, you see true lumen here. So we made a successful swap. We're feeling comfortable. And here in just a second, you'll see the transition point here. And what you can see is the true lumen's off here. It's often kidney shaped. Now we're in the extra plaque space. So this is important from a sizing perspective and to know exactly how far distal I have to stent. One thing about the extra plaque or subintimal space is that we always downgrade the size of our stents by about half. This is not data driven at all, but we know there's less tissue connecting the artery here, right? Because we're in the extra plaque space. There's only a few cells of adventitia between you and a perforation, so we tend to downsize our stents by about half in that regard. Then after that, it's just ballooning, vessel prep, stenting, and as you can see here at the end, successful PCI of the vessel.
Fantastic result.
So this patient was discharged the next day, had resolution of their symptoms, weaned off their meds, and did very well.
That's awesome, Robert. Thank you so much for doing that. That really is a tour de force, step by step. As always, I always learn something when I talk to you. So that was fantastic, man. And we'll see you in a month or so for your next video about retrograde. So we're excited.